Welcome to Conversations at the Carter Center tonight. We're delighted to have you all with us to talk about some issues of great concern here in our state. We'll begin our evening's activities in just a moment, but we wanted to welcome some guests we have this evening, including our many supporters of the center and all of you. We'd like to also welcome students who are joining us from Emory University and from North Cobb High School. So welcome here as well, and hopefully this will be one of your civic lessons that you'll take back with you and study with your friends. We encourage you to learn more about our Conversations event. It's a series we hold every year here. It starts with President and Mrs. Carter kicking it off, and over the course of the year we have several other conversation events, and in them we usually feature some of the work done by our staff and colleagues and friends around the world. Very interesting events, and we encourage you to take a look, and you can subscribe through the cartercenter.org conversations. A fact sheet for tonight's topic and the bios of the panelists was on your seat, so I will not introduce them in detail. You can read it for yourself. They're all very distinguished people in their own rights, and encourage you to take a look at that before we go. This is a conversational event, so we're asking that you give us your questions as well. As you came in, you were handed 3x5 cards. There will be people going through the aisles, up and down the aisles, that will take your cards and be brought up here, and we will have a discussion with our panelists. So please feel free to ask anything you want. Write it on that card and let somebody see your hand, and we will try to get to your question, to all the questions, as best we can. This evening's event is being webcast live on the Carter Center website, and it will be archived. So if any of your families or friends or colleagues would be interested in what's going on, and many are, there's a lot of eyes on Georgia right now and how we handle our situations down here. So it will be available in the archive. At this point, it's my great pleasure to introduce our boss and our inspiration here, Mrs. Rosalynn Carter, who has very deep roots in the Georgia mental health system and will share some of those observations with us tonight. Mrs. Carter.
Well, it's really great to see so many people here to learn about the situation in Georgia now. And I have one announcement to make before I begin my remarks, and that is just to tell you that I have written a book on mental health, and I finished it 2 days before Christmas, and it'll be out in May. So this is my little advertisement. I want to welcome all of you here tonight. We're really pleased to have you, and we have an important program for you, one that's very close to my heart. It's something that I've worked on for so long. Our topic is the current crisis in Georgia's public mental health system, which unfortunately is all too familiar theme in Georgia these days. I first became involved campaigning for my husband when he ran for governor. There had been a big expose of Central State Hospital in Milledgeville. It was overcrowded and just terrible conditions. It was happening all across the country. And then the Mental Health Centers, Community Mental Health Centers Act was passed, which called for putting people in community centers, taking them out of the institutions into the community centers. We called it deinstitutionalization. And when I started campaigning, I knew nothing about this because I had not focused on mental health issues at all. So when I began campaigning, every day it seemed like I had somebody ask me, what would your husband, if elected governor, do for people with mental illness, for my aunt or for my son or for my father or brother who's at Central State? Well, I became really concerned about it. And I asked Jimmy, he was getting the same kind of questions. And people were uncertain about what was happening. They were frightened. And one day I was standing at a cotton mill. I was campaigning in Atlanta at a cotton mill at 4:30 in the morning, giving brochures, Jimmy Carter brochures, to people on the shift change, those who are coming off from work and those going to work. And I saw this woman coming from the cotton mill, She was weary, sort of slumped over a little bit, had lint in her hair and all over her clothes. And I said, I hope you're going home and get some sleep today. And she said, I hope so too. But you see, we have a mentally ill daughter at home. And my husband, Sarah, didn't make ends meet for us. So I stay home with her in the daytime while he works. And he stays with her at night while I work. Well, it just touched me so, because I'd been hearing these things over and over. And so that very same day, I was campaigning in Swainsboro, Georgia. And this was a very disorganized campaign because Jimmy got in late when our leading Democratic candidate had a heart attack. And we lost that year because we didn't have, this was the first time he ran for governor. And we didn't have but about 8 weeks, I think, to campaign. But I heard he was coming to town. As I said, it was a disorganized campaign. And so I stayed, because I had just been in the car with one of my sons, driving from one town to another, stopping, passing out brochures. And I stayed and had a big rally. And I got in the back of the room. He didn't know I was there. And I stood in line with people that were shaking hands with him. And when he got to me, I don't know about you, but receiving lines are part of my life. And I will reach for somebody while I'm talking to the one in front of me. Well, Jimmy did that. He reached for my hand, and when I got in front of him, he said, "What are you doing here?" I said, "I came to see what you're going to do for people with mental illness when you're governor of Georgia." And he said, "We're going to have the best program in the country, and I'm going to put you in charge of it." Well, of course he didn't put me in charge of it. But we had the Governor's Commission to Improve Services to the Mentally and Emotionally Handicapped. And that was the beginning of my education about mental illnesses. And we did some good things in Georgia. And when I was thinking about this tonight, I knew that Stan Jones was going to be here because his wife was here. And Stan, who's sitting right here, was a college student that came and worked with me on mental health, and I've been working with him ever since. Beverly Long, that some of you may know, I think there were 5 advocates for mental health issues in Atlanta. They all descended on me, all 5 of them. That was literally, this was a time when nobody talked about mental illnesses. Nobody would admit having a mentally ill person in the family. And it was just a really tough time to be in the mental health field, but we plugged away at it. And one thing that I think Stan will back me up on this, because I looked at a book I wrote later, and when Jimmy was governor, we established 134 community mental health centers. Now, these were not comprehensive community mental health centers. Sometimes it was a telephone in an office, but we tried to get one on Main Street, a busy place in a community, a place where people could go to find out how to get help. And I was really pleased about what we did. Things did eventually get better, and Georgia at one time had a public mental health system that functioned well and was ranked above average for our nation. And tonight, John Gates is here. John Gates is another that I've worked with for a long time. He was the head of Georgia Regional Hospital, is that right? He'll tell you anyway, because he's going to talk about how we got to having a really good mental health system in Georgia. Unfortunately, now we're back in a crisis situation. And to be clear, and I think I have to say this, because the deterioration didn't start in this administration, so I'm not talking about anybody particularly, but it's just more than a decade of neglect. And there have been questionable policy decisions and budget redirects away from community centers to hospitalization. And if we're ever going to get out of this situation, we have to refocus attention on services in the community that are organized around promoting recovery. And today we know that people can recover from mental illnesses. And the system will have to include services that ensure stable housing. These are things that are really important for people who have mental illnesses. Employment opportunities included supported employment, expanded support services, including peer supports, which you'll hear about later tonight, and a sound system of patients moving out of hospitals in a timely manner and into effective community-based services. Andrew Penn from the Bazelon Center for Mental Health Law is going to talk about some innovative programs, things that other states are doing, even in the face of similar budget constraints like we have in our state. Charles Willis will describe one really innovative program that began in Georgia. It was developed here, and it's being now replicated across the nation and even internationally. Certified peer specialists. This is what we are going to hear about tonight. Again, let me welcome you and say how pleased I am for you to be here tonight so that you will be familiar with what's going on in our state. And we're probably going to need your help to get things going for a really good system, so you can talk up how much we all need to do to be sure we have a good system in Georgia to help those who are living with mental illnesses. Thank you for being here, and I'm going to turn the program back over to Thom.
Thank you, Mrs. Carter. Before we get started tonight, we thought we would go through a little bit of data. Got to do a little data in any meeting, and tell you a little bit about how we got involved in this. The mental health program at the Carter Center works on a variety of issues, generally at the national level and somewhat internationally. We work often behind the scenes in quiet ways, working with partners all over the nation. This was a little bit unusual for us to get involved at this level of detailed activity at the local level. But we became quite interested in what was going on here and felt it important enough to lend our voice. In fact, before we engaged in all of these activities, we talked privately with a number of friends and colleagues around the state and the city, including John Gates sitting here tonight and others, Darrell Gay's here. Do we offer any value added? We were concerned that there had been over 2 years of rather staggering articles in the AJC about suspicious and unexplained deaths in our hospitals, and we were gravely concerned that there wasn't a lot of traction on doing something about that. The advice we got from our friends and colleagues was, yes, get involved, and get involved particularly at beginning to mobilize some of our friends in the community, which is what we've done. And we have lots of friends, and some of them are here tonight, who've worked tirelessly with us on these issues. The Georgia Advocacy Office, Bronco, I see you out in the crowd, and a number of other people who have inspired and led in some of the efforts and gotten us to where we are today. There's going to be a number of things talked about tonight or referred to, different kinds of lawsuits, and we're not here to get into that sort of thing, but to tell you they exist and they're going on as we speak. We became actively involved in a more formal way as a friend of the court in February 2009 and have engaged in a series of conversations between the state, the Department of Justice legal team, and our advocacy group. Here's some of the symptoms. If you're looking at the symptoms of a system in decline, this is a case in point. These are numbers of admissions to state hospitals in selected states around the union. They are numbers of admissions, not admission rates. If it was admission rates, it would be higher. It'd be off the scale. And what we see here is Georgia has roughly 4 times the number of admissions to our state hospitals in the period 2002 to 2005 than the state of California, roughly 3 times our size. Something's going on here. This type of pattern will often reflect problems in the community system. The irony is these high admission rates speak more to what's not going on in the community than what's really going on in the hospitals. It also reflects a pattern of recycling of people, meaning people come in, they get stabilized, they go out in the community, services in the community are inadequate to follow up, and they have to get readmitted. So this is the pattern we were looking at. And this is from an article from 2009. I should point out, by the way, the other states, North Carolina and Texas, which also spike here, are having similar problems in their community systems, particularly North Carolina, which has had a system meltdown. Here's another area that reflects maybe why we've gotten to the place that we are, particularly in the area of practices within the hospital system. We have this tremendous demand on admissions, but resources in real dollar terms, in fact, are going backwards. So you're having a clash here between an increased service demand and a decreased ability to meet that demand in an effective way. I mentioned that there is litigation underway. The suit, one suit is a suit filed by the Department of Justice called the Civil Rights for Institutional Persons Act. It looks at conditions in institutions where there may be reason to believe there are civil rights violations. The Department of Justice runs the CRIPA suits, as we call them, and their team has been down here on a number of occasions visiting virtually all of our state hospitals. Concurrently, we have a case pending called the Olmstead case. The Olmstead case is famous for a lot of reasons, one of which it's a Georgia case. The original Olmstead case was filed in 1999. And what it says, and I'm oversimplifying it, is that people who are living in an institution when deemed appropriate for discharge should be discharged in a timely manner to the services that they need. It was a case filed against the state of Georgia. It's in its 10th year. We had a 10th anniversary celebration earlier in '99, and there is still not an implementation plan yet. Hopefully we're getting pretty close, but there hasn't been. So you have these two ongoing parallel processes. The Department of Justice looking at the conditions within the institutions, and a group in the Department of Health and Human Services Office of Civil Rights, totally different organization, that's looking at the community system and receiving people in the community in a timely manner. These were some of the statements that were made recently. Some of you probably saw the article in late January from Alan Judd. Alan was one of the two writers that wrote the very long series, A Hidden Shame, in Georgia's mental health system. Very good investigative reporters, and they continue to, Alan anyway, Andy has since retired unfortunately, but Alan is following the case. And I just point out that one of the biggest concerns are these four areas of priority: prevention of suicide, assaults, choking, and more effective emergency medical treatment. The Department of Justice filed in January of 2010 seeking appointment of an independent monitor, and that's pending before the courts. What does this all mean for us? It means that the courts, according to the recommendation from Justice, is that people need to get discharged from our hospitals. And some of that is happening. But they need to go to the right places, or we repeat the cycle that we showed earlier. And that's where the problem lies. We're going to conclude right now for those that information and get to the discussion. I think the discussion will be far more relevant to informing you on things that can be done, have been done, times when we didn't work so well and we got better, and maybe give us some roadmaps to how we can get better again. And I invite my colleagues to come up. Can you all hear me now? Good. We apologize for the delay while we accommodate technology. Turn off our cell phones. And turn off your cell phones. As I mentioned, you have the bios on all our participants, our panel members today, and I urge you to take a look at them. Our first panelist that's going to present tonight is an old friend and colleague, as well as a panelist. John Gates has those deep roots we were talking about in the Georgia mental health system, and he's going to talk to us about that tonight. He was also a former director of the mental health program here at the Carter Center, so he's alumni as well. And John, you were the director of the Division of Mental Health, Mental Retardation, and Substance Abuse for a number of years, but you held a number of other posts within the state, and you've seen it when it was in bad shape, and you've seen it when it improved, and perhaps you could walk us through those periods of time.
Thank you, Thom. First, let me say good evening, ladies and gentlemen. It's a pleasure to be here, and I want to thank Mrs. Carter and Thom for inviting me to participate. Thom said I've got about 5 minutes, so I want to start in 1969, when I first began working in Georgia, and bring us forward year after year. So if I
Thanks, John.
In my experience, it's now 41 years as working in Georgia state government and then serving on a number of boards of not-for-profit agencies in the state. I just want to state it outright that I've come to the conclusion, as have many of the advocates that Thom alluded to, and that the problems in our state hospitals that have been reported, as Thom said, in the Atlanta Journal-Constitution and have been reported in investigations by the Department of Justice. My belief is you can't fix those problems by focusing all of your energies on the hospitals, that what's really required is to expand an appropriate array of services in local communities. And it's my firm belief that the overwhelming majority of people with mental illnesses, developmental disabilities, and addictive disorders can be more effectively served in their local communities if you've got the right services in place. In the 41 years I've seen bad times, and I've seen better times, and unfortunately, cycles of those again and again. And I think, as Mrs. Carter has indicated in the recent reports about the problems in our hospitals indicate, we're in pretty bad time right now. And as Mrs. Carter said, these problems haven't occurred overnight. They've occurred over years of neglect. And they won't be fixed overnight, and I think it's important for all of us to understand that. I want to share a little anecdote with you first, and then quickly address the basic question that Thom asked me to talk about before we got here, which is totally different from what I prepared to say. But the personal anecdote is that I began working in 1969 at Central State Hospital in Milledgeville, Georgia, as a psychologist. One of my first assignments was to supervise the staff in the division that had housed about 700 people with developmental disabilities. My job was to teach the staff how to work with the clients there to help them with their personal needs, their toileting, so that they anticipate using a bathroom rather than going anywhere on the ward whenever or wherever they were. One of the other programs was to try to teach people how to feed themselves properly so that they got the benefit of their meals, rather than sitting down at the dining room table with a tray in front of them and grasping fistfuls of food, shoving those into their mouths, one after another, and then be up from the table within a minute or two. And so what we were trying to do is teach people how to supervise and get people to use a spoon appropriately. And the other major undertaking was to get people to learn to put their clothes on and keep their clothes on all day long, rather than take them off and run around the ward naked all day long. One ward in particular stands out in this area for people with developmental disabilities. It was an area designed to accommodate 30 people. When I got there that hot August day in 1969, there were 90 females on the ward. The two attendants, staff who were usually on duty to serve those people, kept the ward clean by hosing it down twice a day. The floor was sealed concrete with drain holes about every 15 to 20 feet. And that was the only way that ward got clean. They'd follow it up with a spray of some sort of bleach. And I see I'm out of time. Is that the gist of? Okay, thank you. Those were bad times, without any question. But they were starting to get better. Mrs. Carter had already started advocating for the needs of people with mental illnesses and developmental disabilities when Governor Carter was in office. She was making people aware of things. Federal government had funded community mental health centers. The state had embarked on a multi-year plan to build regional hospitals throughout the state and population centers to take the pressure off that remote state hospital in Millersville, which they did. So there were signs that things were improving. And indeed, for a number of years, they did. At Central State, after several years, I happened to get appointed administrator. And these next 2 points, what I did at Central and up here in Atlanta as the state director, are what's most germane, I think, to the debate that's now going on and the issues that are taking place. What became clear to me at the hospital was that we needed to develop a very concrete plan to move forward over several years to meet national standards of care. And so we started talking. There's an entity called the Joint Commission on Accreditation of Healthcare Organizations, which sets national standards. And so with my key colleagues, we said, let's strive to meet national standards. Let's set out a concrete plan. By the end of year one, we're going to do this, that, and the other thing. And we're going to monitor what we plan to do. We're going to meet monthly with the leadership of our various divisions and see how we're doing. It was that concrete plan and the buy-in from the staff and their belief that they could do what needed to be done. Within 3 years, the hospital was accredited for the first time in its 140-some-odd year history. Landmark kind of thing. I cite that because of the two elements there. Getting clear about a vision for what ought to be done, and getting leadership to buy into that, and then developing a very specific plan to get it done. Those of you who are in the business community, who have ever developed a business plan, know exactly what I'm talking about. If you need to go get money to start your business, you've got to get crystal clear with who the folks or organizations that might give you the money about what you're going to do, how you're going to do it, when you're going to get it done. So that worked there. After a while, for, again, puzzling reasons, I was appointed state director. And when I got to Atlanta, and again was oversight responsibility for the state hospitals and contractual responsibilities for the community-based systems that were then in place. And Georgia had approximated some very good services. What was clear was that, again, what was needed was a very concrete plan of implementation to fund an adequate array of services in all of our communities where they were needed. And so again, with the buy-in of key colleagues and all stakeholders, consumers and their families, providers, professional providers, advocates, and elected officials, we developed a plan that became known as the Target Area Plan. Over X years, as the money would become available, we would expand in 3 to 4 areas a year. What was important about that is that everybody wanted to be first. Everybody wanted to be expanded the first year. You couldn't do it. Money wasn't there. But as long as everyone saw that if they supported this plan, they got behind it, even though they might have to wait 2, 3 years, they did it. And the state legislature and enlightened leadership in the governor's office, once they understood the intent and the realization that this was not an endless abyss of requests for money without outcomes, they got behind it. And I think that's what Georgia's again missing right now, the absence of that vision of what ought to be over a limited period of time, but a couple of years, and a clear sense of how to go about getting that done. And I go back to say, I think most of it, the money, what that might become available, needs to be in the communities. Think of it this way. Imagine if you found your basement flooding from a broken water pipe. Would you rush down to your basement with as many buckets as you could find in the house and spend all your energy throwing one bucket of water after another outside? Or would you first go to the water supply valve and turn off the water? I think funding the community programs is like turning off the water supply. That's the way to address these basic problems that we now have in our hospitals, not by going down in the basement and pouring all of that energy into the hospitals. Thank you. I'm sorry for
Thank you, John.
going beyond that.
Thank you very much. And I remind you all, the cards that you were issued, please put your questions on it. People will be walking around collecting them and giving you additional ones if you need them. Andy, you've got the envious job of getting a national perspective on mental health services in challenged states. 47 states in the union are facing significant budget shortfalls and pressure on service delivery. Tell us about some of the things you've found in the course of your work.
Thank you, Tom. Is this working?
Yep.
Good. First, I want to say just what an honor it is for me to be here and to meet Mrs. Carter and President Carter. And I was struck by the fact that when I met you just now, I had a flashback to the year I graduated law school, 1977, and came to Washington, D.C., idealistic, ready to go, and there were 2 other people who came that year, and it was you and your husband, and I distinctly remember your fighting for mental health causes. I was intrigued by it because I really didn't know anything about the issues, and you were an inspiration to me then. You and your husband and your work since then have been real inspirations to me, and I thank you. I want to talk a little bit about, first, some of the problems that are facing the adult mental health system today that are preventing provision of good care, and then some of the solutions to those problems. Many of these problems are actually long-standing, and they're pretty succinctly stated in the President's New Freedom Commission report back in 2003. One of them, of course, is the pariah of fragmentation of services. You've got federal government funding the services, state and local governments implementing programs. Then within the state, you've got lots of different agencies with varying responsibilities for different parts of the mental health system. And how do you coordinate it all? How do you access the services and make sure that people get precisely what they need without driving them batty, just figuring out how to get what they need? Then, of course, you've got the decades of just underfunding of community-based services. And then the issue that my office has been working on a lot is just the heavy reliance for years and years on costly and unnecessary and illegal segregation of people with mental illness in a full range of institutions, not just hospitals. Hospitals, it's the one that's always out there, but hospitals, nursing homes, adult care homes, institutions of mental disease, prisons and jails, full range of institutions people really don't need to be in. On top of all these long-standing problems, you've got today's financial crisis and affecting every state, not just Georgia, in some states more than Georgia. So what are the solutions? How did states achieve the right mix of inpatient and community-based services, and then how do they fund the necessary community-based services? I think we all recognize that in the present financial state of most states, it's increasingly difficult for states to go to for state governors to go to their legislatures and say, cough up new money for the community-based services. And it's even harder, though, to justify the continued waste of money for unnecessary institutional services, expensive and unnecessary. Now's the time, really, and a lot of states are doing this. They're thinking, well, are we really making best use of our limited resources? How can they best be spent? And the obvious answer, and it's an answer that's been out there for a long time, is to stop putting the money in the institutions and put it into the community. And there are a couple steps you've got to take in doing that. You first got to really figure out, well, how much of our money is going to unnecessary institutional services? And then, and again, we're not talking about just hospitals, we're talking about a bunch of different institutions. And then how much of that can we reallocate into the community? The funding of institutions is a great existing source of money for states to take from and put where they're really needed. It doesn't just save money. I think most importantly, although this doesn't always get results from legislatures, it saves lives. How do you go about that? There are systematic ways, and several states are doing this right now. First, you really need to get a specific understanding of how many beds your hospitals really need. People get afraid of, they're going to close the hospitals, they're going to downsize the hospitals. Well, 5 minutes. The real word is right-sizing the hospitals, figuring out which beds we really need. How many beds are being filled just by people who should have never been admitted in the first place? And the only reason they got into the hospitals was because there weren't community crisis services to help them before they got into the hospital. Then you got to look at, well, how many people are in the hospital but have been ready to leave, and the only reason they're stuck around, really, is because there aren't the community services out there. Looking at that, you can then make a really reasoned assessment of how many wards can be closed and how much savings can be derived from the closure of those wards. And it's with each ward that's closed that real savings can be derived. These are big-ticket items. The state of New York listed in its state budget, its governor's budget message last year, did this kind of assessment, and they figured out, I'm reading this because I wouldn't have remembered it otherwise, that they could close 450 beds in their state hospitals, and that would save them in the first fiscal year $16 million, in the second fiscal year another $23 million, of which a large percentage of which they were able to translate into funding for supportive housing in the community. There's no reason Georgia can't do the same. You also need to do a careful assessment of what kinds of community services you need and how much of them how much needs to be expanded and what they're going to be costing. Another source of funding for these community services, it really goes hand in hand with the reallocation of money from the hospitals to the community, is the importance of maximizing available federal funds. And that's for community services. That's primarily Medicaid funds, but there's also increasing amounts of money from HUD for housing and supportive housing services, and there's some money from SAMHSA. But Medicaid funding is key, and Medicaid can, if structured right, your state's Medicaid plan can take advantage of funding for a full range of psychiatric rehabilitation services, recovery-oriented services that focus on skills training, assertive community treatment, case management services, supportive housing services, peer support services, life skills training, family support services, crisis services, the full range of services that are an integral part of any meaningful community system. And I think one of the key things is supportive housing, permanent supportive housing. And it's a key service, particularly if we're dealing with people who have been institutionalized for a long time and need more intensive supportive services in the community. Supportive housing is just a proven way of dealing with the issues. And we're talking about scattered site supportive housing, not trans-institutionalizing people from an institution into a housing project that has only people with disabilities in it. We're talking about putting people in their own apartments, a truly integrated setting in permanent apartments, not transitory, individualized services, voluntary services, services that people want, not services that they must take as a condition to living in their homes. And flexible services that can range anywhere from 24/7, depending on a person's needs, to drop in every so often. Again, it's what a person needs and wants, and consumer choice is crucial to the success of permanent supportive housing. And it's this whole notion of consumer buy-in that makes supportive housing so successful, and the notion that if a person has his or her own house, that incentivizes that person to want to do well, as opposed to someone standing over their head and saying it's time for you to stop talking. That's what that person's saying to me. Saying, you've got to do this or we're going to kick you out of the program. So supportive housing works. There's a great program up in New York called Pathways to Housing that is just the model for others that have been burgeoning throughout the country. New Jersey now has a really expansive supportive housing program. San Francisco has one. Illinois increasingly has one. And I can talk on and on. There's a handout outside there are two handouts that talk about supportive housing, its benefits, and how states have gone about funding them. And I will stop right now, and maybe I can provide some more information during question and answer.
Thank you, Andy.
Thank you.
I remind people to use your cards if you want to get some more ideas out on the table. We wanted to leave time to get your ideas out as well. Charles, you've been in the forefront of one of the real innovations that Georgia can be quite proud of. Perhaps you can give us a walk through the peer support movement and the wellness movement now that has emerged from it.
Thank you, Thom. But before I get started, let me first reach out to Mrs. Carter and thank you for the opportunity that you allowed this symposium to take place here at the Carter Center. I had the opportunity tonight to shake the hand of former President Jimmy Carter, which indeed was a insightful event for me. And you have to realize, you're talking about a person who had given up on living and was hopeless and thought my life would end in the parks with a brown paper bag in my hand, lying on cardboard. But I sit before you today with the credential ITE, which is to say I'm the evidence that recovery works. So I say to you, Mrs. Carter, and to Thom, and also to the Carter Center donors and the guests, and of course to my peers from the Georgia Mental Health Consumer Network, my peers from the PAMI Council, and of course other stakeholders groups that have come, members that have come out tonight. I really appreciate you being here, especially to hear from this panel of experts. But what I want to do is do a flip from what you've heard already. Inasmuch as Thom has given you the highlights of what's wrong, John has also talked about the history of Georgia, and then Andy has indicated some of the things that he has noticed across the nation. But we look at it, and I say we, I'm talking about the Georgia Mental Health Consumer Network. I'm talking about consumers of mental health services here in the state of Georgia. We see out of crisis an opportunity. We see opportunity. This idea of leadership that was alluded to earlier, we say nothing about us without us. And I think the state of Georgia has failed to recognize the leadership that it has in the consumers that are receiving services here in the state of Georgia. We all know that 1 out of 4 families are impacted by mental illness. But let me just give you a history of the Georgia Mental Health Consumer Network. One of the greatest strengths that we in Georgia have is the public-private partnership between the Georgia Mental Health Consumer Network and the state of Georgia. And of course, the Georgia Mental Health Consumer Network is a statewide consumer organization here. The relationship we have with the Department of Behavioral Health and Developmental Disabilities has fostered a relationship whereby we have worked, despite the inadequacies of what's here in the state, we have worked tirelessly to grow and to become internationally recognized a peer support movement here in the state of Georgia. So let me just give you a recap of some of the great things that have been taking place here in Georgia that very seldom gets the highlight of the front page or anything else, but certainly says to you how important or what roles we've taken as individuals living with mental health diagnosis to foster a relationship not only with the state, but with other stakeholders, both private and public, and to use our expertise in fostering growth here in the state of Georgia. I think one of the things that we can look at from the past is to say that perhaps the leadership in Georgia didn't foresee the influx of people into this beautiful state of opportunity. And so therefore did not plan accordingly to be able to address the needs of those people who are coming into the state. And again, 1 in 4 people are impacted by mental illness. 10 years ago, the Georgia Mental Health Consumer Network applied for and received a federal grant. It's called the Statewide Consumer Networking Grant. And this grant was from the federal government, and it allowed us, the Georgia Mental Health Consumer Network, to establish what's now known as the Certified Peer Specialist Program. Now, the good thing about this is that the state, first of all, in the relationship, promised to support and fund the project if we got it off the ground. Well, the fact of the matter is, we got it off the ground and they continue to support it. We now have over 700 consumers of mental health services trained with over 500 certified peer specialists that have been able to receive that certification. And we bring a unique lived experience perspective to our mental health system, thereby having a unique ability to connect with and link with peers, assisting them to set life goals and moving forward with lives of meaningful purpose of their choosing. One of the great things that grew out of this was the certified peer specialist's ability to bill Medicaid for the services. Now, these services include peer support, assertive community treatment teams, and community service individuals. Now, this is both in the public and in the private provider settings. Certified peer specialists also serve unique roles and projects that the Georgia Mental Health Consumer Network has been able to bring forward due to this public-private partnership with the state. This includes, but is not limited to, the Peer Mentoring Project, where 2 certified peer specialists work in regional hospital areas to link with consumers transitioning into the community and supporting natural types of supports in community settings. This also includes facilitators of Double Trouble in Recovery. Double Trouble in Recovery is a 12-step model recovery program for people who are dually diagnosed. There was a time in the past when people thought that mental health and substance abuse were entirely different, but now we know they feed off of each other. Okay, so the support is provided before and after the DTR meetings. Also, coordinators and directors of the Self-Directed Recovery Project, which has trained thousands of consumers in developing a wellness recovery action plan, better known as the RAP for work, and psychiatric advanced directives. The statewide Peer Wellness Initiative Project, which has trained hundreds of people in mind, body, and spirit wellness. Because in 2006, the National Association of State Mental Health Programs Directors discovered that the head was attached to the body. And finally realized that we were whole people. So our new Peer Support and Wellness Center that's located in Decatur, Georgia, is a unique project that is staffed by certified peer specialists who support people with 3 respite beds up to 7 days or 7 nights who need 24-hour supports. It's an alternative to hospitalization. A 24/7 warm line to provide peer supports over the phone, and day wellness activities for people who wish to move forward in their lives, supported by peers and certified peer specialists, utilizing the intentional peer support model created by Sherry Mead. This is a unique program in Georgia, one of its kind, but one we would like to see on every street corner or in every region, whichever comes first. We're optimistic that during this time, a few other things have happened as well. For the first time in history, consumer stakeholders have gotten together, mental health stakeholders have gotten together to forge programs or to work together for programs that we can all work toward and agree upon. We're not as in silos as before, but in fact are working hand in hand to create an environment that will support recovery here in Georgia. Understand also that the certified peer specialist model training has been duplicated throughout 26 states, and the beauty of it is that Medicaid provide providers with an opportunity to bill for the services that we offer. Again, nothing about us without us. We ask only to sit at the tables with those creating the policies that will impact our lives. We're only asking that we be considered in helping to support and plan the projects that we feel that would benefit us, because we are the experts. We know exactly what we want, we know what we need, and we know what doesn't work. And if ever is a time to listen to the experts, it's now. Because what Georgia has the opportunity of doing now is creating a model of recovery here in this state that can be used as a model throughout this nation. One that says, despite the limited funding that we have here in the state of Georgia, we believe in recovery for everyone. We believe that we are not, first of all, diagnoses, but are people like everyone else, people looking forward to engaging in the community and living the lives of their choosing. Again, it's an opportunity for Georgia to speak loudly and clearly that recovery for everyone is possible, no matter what the deficit is monetarily, but that the will of the people here in Georgia is to create an environment that supports the need of people who are willing to take personal responsibility for their wellness. Therefore, limiting the number of hospital beds needed. Also, decreasing the population in jails. Also, in decreasing the number of people who are being in county jails, being housed without any medication of treatment. So we ask the public to join us in creating an environment whereby we can foster relationships with the legislators to make sure that what we put together is something that will stand and will create an opportunity for Georgia to shine in these desperate times. And thank you.
Thank you to all our panelists. We'll be getting the questions from you all in just a moment. But while we're waiting for them, I'd like to go back to you for a moment, Charles. You're a person who has seen both sides of the system as a recipient of services and a provider of services. And I'd like to hear more from you about the more that people, what are those active ingredients that do lead to recovery in your view?
Actually, there are 5 key recovery concepts for those who choose to engage in recovery. First, there has to be some essence of hope, whether it's embedded inside or whether it's an opportunity to see someone who flew over the cuckoo's nest and realizing if he could fly over the cuckoo nest, so can I. Personal responsibility. If I'm willing to work toward what I want my life to look like, then I have to take some actions maybe for the first time. And it may not be those actions that I'm accustomed to. I may be afraid to take those actions. But unless some action is taken, nothing is going to happen. It takes education. Education to realize that we're more than a diagnosis. There are opportunities out there. There are supports in place that can help us to get beyond this stigma of diagnosis and learn to live in the community without posing any threat to the general public. Also, it comes with self-advocacy. The Georgia Mental Health Consumer Network, along with the PAMI Council and the Georgia Advocacy Office, has been shouting from the rafters this need for people to stand up and to suit up and to show up and let their needs and their rights be known. And fifthly, there has to be support. Not so much monetary support, but the support of family, peers. We would love to have the support of our providers, but that's not always the case, because if we get well and stay well, some of them may be out of business. But it's an opportunity to foster relationships where we're all working on one accord, and that is for the well-being of the individual that's being served.
Great, thank you. Andy, tell us a little bit more about active ingredients of a different kind for system reform that you've seen. What have you seen as some of the key elements that have helped states despite big challenges? And we need to be honest about that. These challenges are real and they're significant.
Yeah. It's a tough question. But I think first you got to get rid of the silos in which services are provided. There needs to be some kind of cross-agency coordination of services. There need to be a full array of the kinds of recovery-oriented services that Charles was talking about. Case management is key, just to coordinate all the services that could be out there. And again, it's case management that needs to be guided by the recovery principles, individualized, with real input from consumers. There needs to be a real emphasis on evidence-based practices, and that goes...
Could you define that a little bit? Some of our audience might not be familiar with that.
Well, evidence-based practices are practices that have been proven through research to work. I mean, I'm not an expert but I think that's the real layperson's definition, this layperson's definition of it, that have been proven to work, and if certain particular principles are followed. It's called a fidelity model. That's got to be part, and each type of evidence-based practice has its own list of fidelity elements that need to be part of it. If you veer from the crucial elements, the results won't be good. So that supportive housing is one type of evidence-based practice, I think. Assertive community treatment is a key evidence-based practice, which involves teams of professionals providing, not solely professionals, but an array of providers providing services to individuals at a reasonable case ratio, so that individualized services can be provided. People that go out to the community, to the person's home or wherever to provide the services, and don't require a person to come into the office. Services, peer support is a big part. Do your peer supporters, are they part of an ACT team?
Some are.
Some. That's a key element, I think, in the ACT teams that I have seen.
ACT, assertive community treatment.
Assertive community treatment. That and assertive community treatment, I think, has worked particularly well for, it's 24/7. It can be available when you need it, as you need it, and as often as you need it. And it's not, I mean, not everybody needs assertive community treatment, but it is a level of intensity that's particularly important for people with the most intense needs, and that is often people who have been stuck in hospitals for years and years, or in prisons for years and years, whose only reason for being stuck is that there weren't the support services in the community. Again, supportive housing is just vital as a key component of any good mental health system.
Great, thank you. John, we had a question from the audience that if more money was made available from transitioning from hospital to community, what would be the risks of actually worsening the situation for consumers during that transition period?
That's an excellent question. I think some funds do need to be devoted to addressing the immediate health and safety issues that exist in the hospitals. And it's estimated in the last 10 to 12 years over between $100 million and $130 million of Georgia's money has been taken out of the hospitals, and most of it didn't wind up in the community programs. I think one of the things that the state of Georgia needs to do is put some of its money back into the service system. You know, as somebody paraphrased, somebody lose $1 million here, $1 million there, and pretty soon you've got understaffing everywhere. So I think that needs to be addressed.
Indeed. Thank you. To the panel, we've got a question from the floor. There are shortages of providers of all types in this state, but not only this state, and particularly providers for specialized populations, such as children and adolescents and older adults. What kind of steps do you think need to be taken in workforce development at this stage? It's a tough one. Anybody want to try to take a shot at that one?
I mean, it's my experience that if you put out the money, they're going to come run it. I mean, I'm not an expert, but I mean, in other states that I have have experience in, I said, oh, there's nobody out here who does supportive housing. Well, all of a sudden, the state is putting out requests for proposals for supportive housing providers. Here they come. And I think the same can happen with any level, any type of service.
If I could just add to that,
Sure.
One of the things Georgia did years ago was in recognizing the fact that they couldn't recruit the kinds of diversity of professionals that they needed in the public service system, they created a stipend program. Mrs. Carter, it may have been partly on Governor Carter's watch. I can't recall the exact dates. But the idea there was that take a young person who wanted to go, not always young, the medical school, become a psychiatrist, to go to graduate school, to get an advanced degree in psychology, social work, or to go to nursing school. The state of Georgia paid for that education. with the requirement that once the person completed and got their degree, they would come back and serve a comparable period of time for however many years they were getting educated. They would serve in the state system. They get paid. They got a real salary, honest salary for it. But it made a tremendous difference in generating a cadre of a diverse professional group who eventually dedicated several years of their lives to public service.
I think that's a great point. Charles, do you want to add to that?
One thing that's taking place here in the state of Georgia is that senior citizens are getting involved in certified peer specialist training, thereby providing supports to persons who are living in those type dwellings. But let me also go back to the issue of housing. Georgia lacks housing. That is one of the contributors, I think, of why we have so many people hospitalized. There is a movement to get people from the hospitals into the community, but if you don't have the housing available for those persons to go into and live, then you have a problem. I do know that Baltimore, Maryland has a program whereby in high-rise homes, some consumers are allowed to earn stipends that don't impact their Social Security, don't impact their rent subsidies, and they're able to provide supports to persons who wouldn't necessarily have those supports. But it also creates an environment where persons providing those services can earn some extra money and can also assist with the well-being of persons that are living in high rises. So,
Great, thank you.
Just follow up on that in terms of the housing, how other states have gone about dealing with this housing shortage issue. Several states, at least I think there are about 15 states, have done have done their own bridge housing vouchers. Usually you think of the housing voucher as a federal voucher that's given to a person to help pay their rent, subsidizes about 70% of their rent in the community. Well, you may have also heard about the long waiting lists for HUD vouchers over the years. This is easing up now more recently, but there's still a waiting list. Well, many states have done these temporary bridge vouchers where they will give a voucher to just like the same kind of voucher you get from HUD, they will give a voucher to designated populations, people who meet certain criteria, and they have their apartment in the community, and the voucher stays in effect while the person waits for the HUD voucher to come through. And this has proven immensely successful. New Jersey has one that its mental health department operates. I think Illinois also has a mental health department voucher specifically geared for people who are in institutions waiting for discharge. Other states have their equivalent of your Department of Community Affairs have the same kinds of state vouchers to fund housing. The other beautiful thing about these vouchers is they're easy to get started. You're not talking about big development of capital costs to develop a new building. You're just talking about give a person some money for rent. And it can happen quickly, it can happen cheaply, and it can be very effective.
I do want to go back to the question on training for just a moment, because I think it's one of those questions that perhaps does not get enough public exposure. The average age of a psychiatrist in America is 57. There was a time during the height of the community mental health movement that training was a core component of that movement. And those of us in this audience that are of the boomer generation most likely had some or all of our professional education paid for, generally by the National Institute of Mental Health under a variety of different kinds of training grants for which you had obligations, as John talked about here in the state. The federal government got out of the business in the early 90s. So we're moving on pretty close to 2 decades where there has not been a significant investment in training mental health professionals in this country. And we are an aging workforce. And we're an aging workforce, particularly in services to older adults, where we're facing a tremendous pent-up demand that's going to hit us pretty hard over the next decade. So this is a real crisis in the making in the country, and it is going to be incumbent on us to start thinking about how are we going to get the kind of people we need with the kinds of training that are going to be necessary for the services that we're facing, service demands we're facing over the next recent decades. It's going to be a real challenge. There is a report that was produced and funded by the Substance Abuse and Mental Services Administration called the Annapolis Coalition Report that took a hard look over a several-year period of all the core professions in mental health. It's available online, and you can take a look at it. And for those of you who do advocate, this is one area that probably should be looked at, and there's some stuff around that can help you to do that in a very informed way. It's the Annapolis Coalition, and you can Google it and easily get to it. Another question from the audience, a good one. What can family members do to ensure their loved ones are being cared for properly? Tough one.
From my perspective, it would be essential that family members get involved and educate themselves about treatment protocol. For instance, for a long time, providers and professionals have established what our treatment plans would be. And as a result, some of us have failed at meeting the demands of someone else. Therefore, we weren't kept in the loop in terms of no one asked us what we wanted to do. It was just decided what we should look like once we're in the recovery model. But I think families should ensure that any treatment plans that are formulated are plans that, in fact, the Consumer Mental Health Services has, in fact, agreed that this is something that they want to do. One of the motivating factors behind that is the incentive. If it's something I truly want to do, then I'm going to work toward doing that, as opposed to being forced to comply with what's being expected of me. I think families also can educate themselves by attending forums of this kind, by using the web, coming out to some of the trainings that the Georgia Mental Health Consumer Network has available, attending some of the advocacy meetings that the Georgia Advocacy Office has in the community, and also just becoming a part of the listserv at the Georgia Mental Health Consumer Network.
Great.
If I could just build on what Charles has just said, which I agree with wholeheartedly. I think that what families can also do, and I think what Georgia's public system of care for people with mental illnesses, developmental disabilities, addictive disorders needs to have is some sort of independent oversight of what takes place with our clients. The reason I say that is that some percentage of the people who are served in the public system are especially vulnerable to abuse or neglect because of their disabling conditions. And while my own experience has been that the overwhelming majority of people who work in public services are good, well-trained, and compassionate people, there's always going to be a rotten apple. And then sometimes if you get a few of those rotten apples in a hierarchy, things don't surface the way they should. And I think some, is an overworked term today, but some oversight transparency, some independent person, agency is required to have the authority to see what is going on, to respect people's privacy and confidentiality, but to look into things and to periodically make reports about what they find. And whenever necessary, to have the authority and the guts to speak their truth to power to get things corrected.
Thank you all. We've talked a lot about the necessity of housing and supported housing in communities, and I think no one would argue against that. What do you see in the near future for more supported employment and more emphasis on employment? and some innovations on employment? Anybody?
Well, the Georgia Mental Health Consumer Network is partnering with the state, the Behavioral Health and Developmental Disabilities, in providing training for certified peer specialists for persons living with a mental health diagnosis to be able to go to work, or providing support services to those persons who are still receiving services, mental health services. We would like to ensure that at every level of provider services, there is a certified peer specialist that's there. In emergency rooms, perhaps to do some backup and support during a crisis situation when people show up there. Also in integrated care, because in the rural areas, there's a lot of stigma attached to going to the mental health system for services. And so therefore, to eliminate some of that stigma, if there was integrated care, no one would truly know why you were there to see the doctor in the first place, and therefore people would be more ready to step forward and get the treatment they need. Also, in being a part of the centralized government in mental health, opportunities to help direct policy or implement policy. There's a host of things that certified peer specialists can do. The only requirement to be a certified peer specialist is that you have a mental health diagnosis and have a GED or high school education, which is most inclusive, and a 2-week training, of course, whereby upon completing the training and passing the test, you have a Georgia certification. We are the largest provider server, Georgia Mental Health Consumer Network, in the nation. We hire more certified peer specialists than any agency in the nation right now. And that's a shame, in as much as based on the size of our budget. But we would like to encourage other providers to make use of our expertise. And not only that, but the incentive that we have to go to work and not necessarily prove anything, but provide services that we know have worked and to model recovery.
Right. It's interesting. Most of the surveys that I've seen of consumer attitudes and preferences, employment is at the top of the list.
Right.
You want a job, a house, and friends in the community. Sound familiar? I think most of us would argue for that.
Else wants. And it really, I mean, it's the old way of sheltered workshops or paying a lot of money, a lot of state money for day programs where people just sit around and don't, many people just don't like. I mean, these are things of the past, really.
Yeah, it seems that programs like The Village in Los Angeles, that's operated by the Mental Health Association of Los Angeles, is one of those programs that take people who are experiencing significant mental health challenges and getting them in progressively more challenging employment that has real futures to it, where people can grow, where they can find what you talked about, Charles, so well a few moments ago, the meaning and purpose in their life, which is absolutely what all of us seek. Any more that you all know about, like The Village, that take that employment issue very seriously and work hard to get people in progressive employment, not just sort of maintenance employment to keep somebody off the street? Yeah, we'll think about that one a little bit, but I think it's important that we, as we look at stable housing, we've got to pair it with employment. Because that certainly adds to the enrichment of the recovery process. Here's another great question from the audience. Does the cycle of bad to better and back again correlate with the economic uplifts and downturns? Great question. Want to try it, John?
I think it does, to a degree, not entirely. I think when you have enlightened leadership in various positions, even if the economy goes bad, you can make progress. It's that vision of leadership, which includes being clear about what the consumers want: safe place to live, a job, an education, family and friends, and so on. So I think there is that cycle. I think many of the better times have succeeded despite an economy that may have dipped for a while because of multi-year implementation plans that everybody bought into. A multi-year plan is practical because you can't fix things overnight. You have to plan it over time. But there's another side to that, which I want to emphasize to people. In Georgia, the legislature can only appropriate money on a year-to-year basis. And our elected legislators are elected for 2-year terms. And our governor is elected for a 4-year term. We need a way to bridge annual budgets and elected officials. The budget is annual, and elected people come and go, but the people who need services are with us all the time, and the services they need ought also be there all the time. That's the value of a multi-year approach that everybody buys into.
Any other thoughts on that? That is a issue around the reconciliation of cycling. Yes. Good times, bad times. How do you level off over time so that periods like this one can be smoothed out a bit more? Charles, you had something?
Those of us who've been in the mental health system for a while, we have learned to be resilient. Despite what's happening in the economy, we've learned to make use of what we have. But the general population, based on the current economic situation, some of whom are entering mental health services for the first time. The thing that they have that we didn't have at that time is that we didn't have supports from peer supporters to declare that everyone could recover and to show us the way. Now the mental health system has those people in place to engage those first-time persons who are coming in for service for the first time, to give them some feel of the remarkable gift we have to share with each other and to instill in them this hopefulness that they too can recover and get on with their lives. Because we're seeing, as you well know, a lot of people who are seeking services and who are caught up in a lot of despair with the loss of job and all kinds of issues, homes, and so we're just here. We're happy we're in place to embrace those people when they enter the system, to let them know it's not the end of the road, but could be a beginning journey for them.
Do peer specialists go into the hospitals at all and work with people there, helping them transition to community?
We do. We have what's called the peer mentoring program, where we have 2 certified peer specialists who assist people in the transition to the community. But one of the things that is causing a problem, again, is housing. Getting people into suitable housing, not in, what do you call them? I don't want to say old folks' home, for lack of a better. Personal care homes. Because
Nothing wrong with
I didn't want to use that word, y'all, but
Thank you. I appreciate it.
in our opinion, that's not suitable placement. But for the sake of getting someone out of the hospital, it is. And even though there have been lawsuits brought in the state of New York that said that's not a suitable placement, we continue to do it. So.
I have a great segue question that came in from the audience. If community-based programs are the way to go, then how can we best create linkages between inpatient and outpatient care programs? You're getting into that a little bit. Any other thoughts? You guys anticipated the question.
One thing that can really help is involving not only peer specialists, community providers, people who have real knowledge of what's in the community in the discharge planning process, not leaving it to hospitals and hospital staff who oftentimes, more often than not, don't know what's out there, don't know, don't have a concept of what supportive housing, for example, can provide for an individual. They can just, they often take the view of, oh, this guy's been in the community and he's failed, he's going to fail again, he's just got to stay right where he is. Well, the reason he so-called failed is because he was dumped into a personal care home without any kind of support services, instead of being provided the services that he really needed. And experience has shown that oftentimes, more often than not, community providers are the ones who have that knowledge base, and hospital staff does not.
And there's no buy-in from hospitals to promote recovery. I mean, the release, they're done. But if there was some sort of incentive to engage them to be more mindful of what it takes to do well in the community, they may be more interested in making sure that plans were in place that was really going to create an opportunity for that person to recover and stay out of the hospital.
Mm-hmm.
I believe in Georgia, the authority already exists at the state level to direct hospital administrators to coordinate everything with community providers, and through contractual arrangements with community providers to insist that they coordinate things with the hospitals. And there's bottom line money there and jobs at stake. Do what you're told to do, and also do what the contract requires. And so you make coordination, communication, an absolutely vital function. One very tangible thing you can do then is every time somebody has to be admitted to a hospital, hopefully it's not that much, at the time of admission, there's someone from the community staff with the client, and you start planning the discharge of the new admission from day one between the hospital providers and the community providers, with the input of the consumers and the family members. It's done in some model programs throughout the country. It can be done in Georgia.
And often in many supportive housing programs, person has needs hospitalization for is in an acute care crisis. Mm-hmm. They'll hold on. He's not going to lose his house. Right. That's his apartment. He's got a lease, and the provider makes a commitment to stay with that person, and that also helps in terms of making sure that that hospital stay is as short as possible.
Right.
Indeed. Continuity of care, I think, has been implied throughout the evening in a number of different questions in different ways. Where does the glitch happen? Where does it start to come apart? John, you say that the law allows for it.
This is an oversimplification, but it's a leadership issue. It's related to a vision. Get clear about your vision, about where people ought to be served first and best, and you recognize that from time to time that you can't have the ideal, so you just insist that there be the coordination and the continuity. People should not be allowed to fall through the cracks. It's doable. It just requires somebody to say, do it.
Indeed. Another question from the audience. Why do hospitals like Georgia Regional have a closed-door policy whereby family members and caretakers are forbidden to see the conditions of where their loved ones are hospitalized and being treated? Hospitals that have a more open-door policy have a much better environment and treat both the patient and family with higher levels of respect and dignity. Can this be changed? Thoughts?
I didn't know it was closed door, and it shouldn't be.
Yeah.
I'm surprised.
Indeed. All right. Open the doors. Last question.
Actually, I think they should close the front door and open the back door.
I think you've been saying that all night, Andy.
Yes.
Yeah. One last question we have time for, and I ask this with some reluctance. What level of cooperation do you expect is received with insurance companies and the service system? Maybe I'll retract that question.
It's time to go.
The uneasy laughter. Anybody? We will end on that note. I think what
There is now parody.
what we're saying here is that there may be some issues in insurance coverage, and getting healthcare reform has been a little difficult to begin to clarify that.
Well, if we did have healthcare reform in one of its present iterations before the houses of Congress, it would put an obligation on insurance companies to provide the level of services to people with mental health needs, as same as people with regular health needs.
Well, we'll remind the audience, too, we have some good news on that. Mental health parity did pass last year. The regulations are being implemented now, but unfortunately that only covers those people who have insurance. And we have that huge gap of people who don't. And we seem to have lost a little impetus on the movement towards fixing that, but that certainly is, that speaks to certainly the issue of coverage and access to care that I think that question was really intended to get at. We've got a partial fix, but it's a long way from a complete fix. We'd like to thank the panelists for their contribution this evening. We'd also like to thank all of you for your participation and wonderful questions. We'd also invite you to visit the Carter Presidential Museum and Library, which has been completely redesigned and renovated. Just opened on October 1st. It's a real different museum if you haven't been there. Very exciting, and particularly bring young people. It's much more interactive, and there's a large focus on the post-presidency years as well. So it's both the presidential years and the post-presidency. We certainly encourage you to come. Our next program in the Conversations at the Carter Center series takes place on March 10th. And join us for a conversation led by Paul Collier, who's an award-winning author of books such as The Bottom Billion, Wars, Guns, and Votes. He'll be joined by several Carter Center Peace Program directors for a closer look at the impact of elections in Africa and what is needed to make democracy hold in developing countries. You can make your reservations online at www.cartercenter.org/conversations. Maybe we got some conversions tonight. You can also sign up to receive emails about upcoming events at the Carter Center in the lobby tonight or online at any time. We thank you all again, and good night.